So with distributive shock, we think of excessive vasodilation, um, and the most common cause of this will be from septic shock. Some other causes will be from systemic inflammatory response syndrome, known as SIRS. Toxic shock syndrome is from a bad bacterial infection. Um, one of those could be staph infection, and anaphylaxis could cause distributive shock, and this is an allergic reaction. And these causes can actually be identified from looking at the patient's symptoms. So a patient that has anaphylaxis shock will present symptoms of someone with an allergic reaction. So wheezing and respiratory distress can be seen. Something with toxic shock will show high fever and rashes. This can be seen with someone with a staph infection. The patient will present a high respiratory rate, usually above 20. Hypotensive, they'll be hypotensive, so they'll have a systolic pressure below 90. Their extremities will be warm with bounding pulses and early shock. So this is completely opposite than the cardiogenic shock, which is a cold shock. This patient is presenting a warm shock. So this x-ray right here is an 8-year-old boy who had pneumonia and developed distributive shock from the pneumonia. So some hemodynamic findings and monitoring. The pulmonary capillary wedge pressure could be normal or decreased. The cardiac output could be normal or increased. So even with an increased cardiac output, the body has low blood pressure still and low blood perfusion from this distributive shock. So a placement of a pulmonary artery or arterial catheter should be considered. Central venous access should be considered if vasoactive drug support is required for that low blood pressure. So some pharmacologic options, antibiotics should be given at the early stages to really try to fight off that infection. Levaquin and gentamicin will help fight off the gram-negative pathogens, and corticosteroids can be given to help with inflammation. This is actually used if the fluid replacement is not helping the patient either. Vasopressors, dopamine and norepinephrine, they are used as to vasoconstrict the vessels in the body and increase the cardiac output and increase the blood pressure. So mechanical ventilation for a distributive shock. Oxygen should be administered by mask immediately, so maybe a non-rebreather or a simple mask depending on what the patient presents with when they come in. So if the patient continues to have respiratory distress and alter mental status, this will be signs that the patient needs mechanical ventilatory support. Mechanical ventilation can actually aid in hemodynamic stabilization by decreasing the demand on the respiratory muscles. So the patient will initially show with an ABG, if you take one when they come in and they're having a high respiratory rate, they might show respiratory alkalosis by blowing off all their CO2. And then eventually, as their respiratory muscles get tired, they'll show metabolic acidosis with some hypoxemia could be present as well.